Okay, now comes the optic atrophy part, that is neuro ophthalmology. That means if the optic nerve is remain untreated, then there are some kind of optic atrophy. That means destruction of neurons will start to happen. Okay, so the atrophy of optic nerve can be seen ultimately. So, what are the signs of atrophy of optic nerve? That is, first the optic. If this is the optic nerve, it is my optic nerve, and it is my retina, then obviously the nerve comes like this, and it is like that. This in the retina. So the only visible part of optic nerve is ultimately the optic disc that is in the retina that I can see. I cannot see the behind the scenes. Okay. So the first thing, if the optic nerve atrophy can be seen, that is the pallor of optic disc. That the optic disc will be pale. Okay. So let's write this atrophy of optic disc. Signs. First is pale optic disc, that is pallor. First. Second, kiss tin bomb index, that is small blood vessel less than 7, less than 7. Normally in any picture we can see around, if we see this picture, it is the optic disc and there is some pallor. We cannot refine the margins, and if we see, this is the large blood vessel, this large blood vessel, large blood vessel, and these are small blood vessels, and we can trace them. So there is 1, 2, 3, 4. There's very pale 5, and there's 6. So we can only see 6 blood vessels, but 5 to 6, but not 7. Usually seen 7 to 10. So this is Kistelbaum's index. 7, less than 7 seen. Third is visual loss and optic atrophy don't correlate. Okay, visual loss is less with much more optic atrophies. It is same like glaucoma. Same thing is seen in the glaucoma as well. Okay. So now we will see what are the causes behind the optic atrophy. First, types of optic atrophy. If we see the types, there is obviously primary atrophy, secondary third one is consecutive optic atrophy. What is this? This is a consequence of same structures getting destroyed. That is, if this is my retina, this is my optic nerve, and this is the optic atrophy, optic disc. And here the retina gets damaged. Along with the retina, the consecutive structure, that is the optic disc, it also gets damaged, and ultimately I can see a optic atrophy. That means that disease in retina, disease, any kind of retinal disease, it can happen. So what will happen? Example, that is retinitis. No, retinitis. Central retinal artery occlusion, central retinal vein occlusion. Now comes the primary and secondary. Obviously, primary means that optic atrophy due to without any anticentral optic disc swelling. That means it is the primary. It happens happening for the first time, and secondary means there is some other case, the consequence of that causing optic atrophy in this case. That means in existing optic disc swelling, that's why optic atrophy is happening. So primary, if we see the pictures, in the primary the optic disc is pale yellow or white, and the margins can be seen easily. In the secondary, there is swelling, that's why the margins cannot be defined well. Okay. There is blurred margin, and color is little bit faint, that is dark gray. So that's the thing. First, in optic disc, we'll see we can see a primary, a very white or yellowish disc with proper margin, so white or yellow disc, proper margin, proper. Here this is secondary case. There is a pale grayish with improper margin. So the color is not proper, gray we can say. Margin is blurred, blurred margin. Now comes causes. So primary has many causes, like optic neuritis. What is optic neuritis? That is most common case is under here multiple sclerosis. Okay. Most common case. Now we will come to the classification of optic neuritis as well. So there, for example, optic neuritis. What does it means actually? It means optic neuritis means nerve. Itis means inflammation. Optic nerve inflammation. So we look that optic nerve has many parts. Okay, if we see the earlier picture, that optic nerve, this is, there are four parts mainly: optic disc, that is the frontalmost part, then comes the intraorbital, then intracranial, and ultimately intercranial, intracanal and intracranial. Okay, so let's make this. If this is my eye here, this is the eye, and here comes my first my optic disc, then comes intraorbital, that means in the orbit of skull, then intracanal, and then intracranial. There are four parts. Now, the frontalmost part of optic disc is a optic nerve is called optic disc, that is also called papilla. So, in papilla, that is the optic disc actually, swelling can be happen. It is ultimately optic neuritis is nothing but the swelling of optic nerve. Okay, so if the papilla get swells, that means the optic disc gets swelled. We will call it optic papillitis. Papillitis. Okay, and if as a clinician I can only see the entire part of optic nerve, what can I see? As a clinician, I can only see the optic disc part. How? By actually looking through the eyes, I can only see the optic disc part. I cannot see the remaining part because it is inside the skull. I have to make other ways to see it, and I can see that indirectly. Okay, not directly. So now papillitis, that is the optic disc inflammation. So it is most commonly seen in children, and what will happen? It will congest. That means fluid will be accumulated and it will be a bit reddish. Okay, so hyperemia can be seen. That means it will be simply reddish. Reddish. Okay. Hyperemia. Next, retrobulbar neuritis. That means this part, retrobulbar. That means it is the bulb, and retro behind this. That means the second, third, or fourth part of the optic nerve. This is called retrobulbar neuritis. Okay. What will be happen here? Vision will be lost. It is happen in children. It will happen in adults. And the thing will be that the doctor can't see and the patient can't see. Why? The patient cannot see because obviously the vision is lost. So if I write this like vision loss, and doctor cannot see because obviously it is the retrobulbar part of the optic nerve. So as a doctor I cannot see this part. Okay. So the doctor can't see, vision loss for both patient and doctor as well. Next is neuroretinitis. That means it happens as well in this part. Neuroretinitis. And what will happen here? That the macula, it is the optic nerve. Just draw. It is my retina. Here comes my optic nerve. That is the actually blind spot. And beside this there is my macula. That is the most visual part of my eye. Uh, where is the visual resolution is highest in my eye. Both of them will get inflamed. Okay, both of this will get inflamed, and the most important part of this macula, obviously margins will be as well blurred, and I will see a star-like appearance in the macula. So I will write it as macular star appearance. Macular star appearance can be seen. So macular star appearance seen in where? Neuroretinitis. Where else it can be seen as well? It can be also seen in hypertensive retinopathy. That means hypertensive retinopathy. That means if BP is high, retina damage or retinal problems, there can be seen this. Obviously, macula is part of retina after all. Also, papilledema. That is optic disc, that is papilla and edema in optics. Now, the second part is optic neuritis. Here now comes the second part, that uh, how to treat optic neuritis. Okay, so the clinical features in case of optic neuritis. Clinical features will be scotoma, central scotoma. That means macular vision is lost. So obviously central scotoma, optic nerve lesion, macula getting lost, central vision will be lost. That is called central scotoma. Is equal to central vision loss, nothing else. Okay. Central scotoma. Next, color blindness. Mainly red color blind. You can understand which color, that is red. Next, unilateral vision loss. It is very much important, vision loss, and it is painless. And more important, it is sudden. That means patient will say, doctor, I woke up today and suddenly I cannot see anything. I am not having any pain, but I cannot see anything. That means painless, sudden, unilateral vision loss. That means in one eye it will happen, in just one eye. Okay, it is a very important. Next is Uthop's phenomenon. Uthop sign, that means on taking a hot bath, the situation actually deteriorates. That is exacerbation on increased body temperature. Okay, so temperature increase, worseness increase. Okay, next is which sign, that means cannot trace kinetic object. persuasion object cannot trace this kinetic object. This persuasion of object is lost. Okay. Or kinetic object perception is affected. Next is Marcus gun pupil. Obviously, it is the earliest scan. Marcus gun pupil. This is earliest sign. So what is most important among this? So the most important is sudden পেনলেস ইউনিল্যাটারাল একটা চোখ কানা হয়ে গেল, হঠাৎ ঘুম থেকে উঠে দেখছে একটা চোখ হঠাৎ অফ হয়ে গেছে। ওকে, একটা চোখ অফ হয়ে গেছে, বা সেই চোখে আমি পিউপিল আমার নর্মাল লাগছে, বাট টর্চ লাইট সুইঙ্গিং টর্চ লাইট টেস্টে আমি চেক করে পাচ্ছি মার্কাস গান পিউপিল আলটিমেটলি উইথাউট সাইন অন টেকিং আ হট বাথ দ্য সিচুয়েশন ওয়ার্সন অ্যান্ড ক্যান নট ট্রেস আ moving object. Okay, these are the things. Now comes the treatment. Treatment is obviously it is most commonly seen in multiple sclerosis. So multiple sclerosis has a very simple treatment regime, and if we see, this is where to write here. There's very little space in here. So multiple sclerosis happens like this: sudden onset, then everything getting normal, sudden onset and everything getting normal. So my target is simply I have to prevent this. I have to make sure this is lengthened. That means the interval should be more lengthened. Okay, so what we like during the onset, my treatment will be steroids, nothing but IV steroids. That is methyl prednisolone. That is methyl prednisolone, 1 gram daily for 3 days, followed by oral prednisolone plus oral prednisolone. I cannot give this only, not cannot be given because it will change of recurrence will occur. Only given if only given recurrence. Recurrence will. The second thing is I have to lengthen this part. Okay, so what I will give beta interferon. Okay, this is the simple treatment of the entire thing. How it helps? The IV methyl prednisolone and oral IV methyl prednisolone and oral prednisolone, it ultimately does that faster recovery. The thing will recover automatically. The person, the eye that has been gotten off is the person that will automatically come online once again. The eye that just turned off automatically, it will come online once again, but it will take around 4 to 5 weeks. By giving this drugs, it will occur in 1 to 2 weeks, so it will faster the recovery and it will make sure that less chance of recurrence. This recurrence will happen, the chances is less, and final visual outcome is not affected. Ultimately, that's the part. Okay. So this is entirely primary optic atrophy. Primary optic atrophy due to optic neuritis. This has been just one part. Okay. Now comes to the other. Other reasons of optic atrophy, if I see, obviously trauma, tumor, toxic agents. That means ultimately it is nothing but toxic or nutritional optic and neuropathy. Toxic agents, what is this? Vitamin B deficiency, one cause. Second cause, methanol. That means expired alcohol consumption, obviously. And last is obviously the drugs. What drugs? Dice drugs. Means digoxin, isonium acid, chloroquine, ethambutol. So I have one malaria drug, two of tubercular drug, TB drug. What these things actually cause? Ultimately, it cause central, not actual central scotoma, it cause centrocecal scotoma. Central scotoma will happen here. Centrocecal means it will happen here. So centrocecal scotoma. Okay. Last is obviously hereditary. Hereditary optic neuropathy. How will we understand it? It is Zahir, Beher, Leher. Not Leher, it is actually Leber. Lon, Lion. Last is Wolf. This is hereditary, that means it is autosomal dominant. Zahir. Beher is autosomal recessive. Leber is Wolfram, also autosomal recessive. Leber is interesting. It is by mitochondria. Mitochondria is mitochondrial disease, and mitochondria comes from where? It comes from the ovum, and the ovum comes from the mother. So it is the maternal transmission. Okay, so maternal transmission, mom transmit. So what will happen here? It will happen many things. Mainly bilateral vision loss, painless, no inflammation, primary optic atrophy, no treatment, obviously. And it is Wolfram. It is also risky. What happened in Wolfram? It happens in diabetes insipidus, diabetes mellitus, also optic atrophy, and deafness. So these are all primary optic atrophy. All of these are primary optic atrophy. Now we have secondary optic atrophy as well. Secondary optic atrophy. There are mainly two cases in secondary optic atrophy, and we have already discussed one, that is papillitis. So in case of secondary optic atrophy, that is there are two cases. One is papillitis, already discussed here. Other case is that we will discuss now, papillitis. What is papillitis? Papillitis simply says that papilla means optic disc, and edema means swelling. So swelling of optic disc, but why? Swelling of optic disc, and it is also swelling can be happen inflammatory and non-inflammatory. Here the optic disc swelling is due to CSF increased. That means ultimately intracranial pressure increase. I'm not writing that right here. So CSF increase means that it is non-inflammatory swelling. So we can write it non-inflammatory. Optic disc swelling. And if it is non-inflammatory optic disc swelling, that means it will be painless. Obviously there is no inflammation in there. If itis, that means inflammation happens, that means there will be any kind of pain. So how it happens? Why it happens? Now comes the picture. See, if I make, do I have this book making so much pictures? I don't, but I will do this. Let's make the copy first. It is my brain. Okay, this is my copy. This is my orbit. Give him a smile. So what happens? That here is my brain, cranium, and here comes my optic nerve, and obviously this is my eye. Okay, when the CSF increases, the CSF increases inside this part. We all know that here is a dura matter. I am not finding my pen. Yeah, here is the dura matter, dura matter, pia matter, aragonite matter. That is meninges. If the pressure inside this actually increase, that means CSF is actually getting increased, it will cause a pressure on both of the eyes optic nerve. It will simply compress the optic nerve in both of the eyes. That will cause what? That will block the transmission of nerve conduction. Ultimately that will cause a stasis. and in stasis obviously that will make many problems. So let's discuss one by one. So what happens first? CSF increase, intracranial pressure increase. Ultimately, I had to write it in subarachnoid space. Obviously, happens that will cause exoplasmic transport block. Exoplasmic transport, that means simple nerve conduction will be blocked to cause a stasis, that means stoppage. Stasis will cause two things. One is edema, fluid will come out, and congestion, fluid will accumulate. Edema will does what? We already have seen edema does what? It will do blurring of margins. That means ultimately this picture as well. So edema will cause blurred margin. Obviously edema will make swell up the optic disc. Swell optic disc, elevation of optic disc will be seen. If a lot of water is there in the retina, then what will happen? Patton's line will be seen. What is Patton's line? It is nothing but if our fingers got folds, if it is wet for a very long time. So the same thing will happen here. In the retina, we can see Patton's lines. Patton's lines. That is nothing but retinal folds. Retinal folds. The optic disc will look like a champagne cork. Will look like a champagne cork. Obviously, the blind spot will increase. What is the blind spot? The blind spot is nothing but the optic disc. So, blind spot will enlarge. Simple thing. Next, congestion. It means the series, the optic disc will be more reddish at first. Obviously, there is more things. We will see macular star appearance like this here as well. Macular star appearance. And loss of venous pulsation. Oh, that is not very important. Whatever. Now the question comes that why the CSF pressure actually increase? What is causing the increase? So there are reasons, causes of CSF pressure increment can be many, like simple tumor, Graves, orbitopathy. Okay, problem in the orbit, orbital cellulitis. Okay, others like ocular hypotony, that means intraocular pressure gone less, papillitis, inflammation, neuritis, neuroretinitis. Many more reasons are there, not writing them down. So this is the secondary optic atrophy, that is papillary. It is the etiopathogenesis. Now comes the symptoms. Symptoms are very important. What will happen? Earliest symptom, earliest is headache, severe headache will be seen in morning severe after waking up. It is the important viva question. Morning headache after waking up. Okay, papillary. Next, projectile vomiting. The person will simply vomit out things in a projectile manner. So he will have headache, severe headache when in the morning. Okay, severe headache. We will do projectile vomiting. Next is his vision will be normal for papilledema, but due to this papilledema, the optic nerve is getting pressurized. Ultimately, many things is actually happening, and ultimately, it is causing optic atrophy. And due to optic atrophy, there will be painless loss of vision. Why painless? Because it is non-inflammatory. Okay, so vision will be normal, but painless loss of vision will be seen. And what will happen also, that transient visual loss. That means the picture comes, picture goes out, picture comes, then after some hours or time, the picture goes out. The patient says, I have seen a sudden pen picture of kind of thing. That is transient visual loss. Okay, it is called amaurosis fugax. And ultimately, the vision due to papillary edema is normal, but it is causing the optic atrophy that will cause ultimately gradual loss of vision. And it will be what? It will be painless. That is the important. So this is the entire thing, how it is measured by Pheasant's grading. What is Pheasant's grading? It is nothing but, if we see these pictures, in the first picture it is 1 degree, we can see some black spots that are actually hemorrhage. Okay, then we can see here the blooding of margin. This margin is going starting to blood. Okay, here there is no disc margin, here is no blood, major blood vessel cannot be seen, most of them. There is no blood vessel at all, we can see. It is the highest level. So this is all. Thank you. Now comes another thing, that is reasons of papilledema. There are two also others, that is AION. What is AION? It is also a secondary optic atrophy. So what is this? It is nothing but AION is anterior ischemic optic neuropathy. Anterior ischemic means, optic neuropathy means, and it is anterior. That means ultimately it is optic disc problem, and ischemic means it is blood supply problem. Okay, so there are actually two reasons behind this blood supply problem. Due to why? Due to, one is giant cell arthritis, that is also vasculitis. Other one is short ciliary artery problem. Short ciliary artery. Okay, short ciliary artery problem. Here what happens? Here the optic disc becomes pale. Once again, optic disc it becomes pale, and here the optic disc become hyperanemic. That means more reddish. Okay, that's there is nothing to discuss more. It is not very much important. Next is congenital anomalies of optic disc, that is morning glory syndrome. Congenital, this is the picture of morning glory flower. Here, just like the spokes of morning glory flower, here is also seen the spokes in the optic disc, so it is called morning glory syndrome. And next is myelinated nerve fibers, that is retinal nerve fibers carries the myelination intraocularly, given appearance of whitish radiation. Okay, it is no visual loss. So the congenital anomalies of optic disc, if we see that in the optic disc, if it is the here comes my optic nerve. So it is optic disc, then intraorbital part inside the orbit, then canal part, then intracranial part. Okay. Myelination, that is myelin sheath, comes into play in the intraorbital part, then intracanal and intracranial part. Myelination comes here. Okay, that means actually it is like this. Myelination comes here. The optic disc is non-myelinated. What means optic disc non-myelinated? Myelin. Rest of the part myelin is there. Okay. So information I can write it here. Same thing, nothing else. You can just skip the part. This is my eye. This is my optic disc. Then intraorbital part, intracanal part, intracranial part of optic nerve. If I see, this entire part is ultimately myelinated. So this